Now we are live. So, hello everybody. There's another session from Barcelona Rhinology School. Today we are with my big friend, Professor Laura van Gerven. She was our fellow in 2018.
16, 17.
16, 17, sorry. Time passed really fast. Laura, now she's an expert in sinus surgery, an expert rhinologist in the whole sense of the word. And I asked her to tell us her experience treating complication of acute rhinosinusitis. They are rarely seen these days because of antibiotics, but it's a very interesting topic and a very important topic because we still have very how do you say it? Very like complication and severe complication from acute rhinosinusitis. So that's why this topic is so important. So good evening, Laura.
Good evening, Cristobal.
For accepting my invitation, for giving us your time and for preparing, and then now talking about your experience. Now I will put your slides. Just a second. So,
okay, perfect.
It's for you.
So good evening, everybody. So I'm working currently in the University Hospital of Leuven, where I was also trained. And I will share tonight with you our experience in treating complications of acute rhinosinusitis in children.
Oh, so you can put like presentation mode. I think it's better.
Okay. I'll give a short definition to come to the incidence and to the etiology afterwards. I'll focus on the diagnostic workup and the treatment because I think these are the two most important topics of the talk of tonight. And I'll end with some take-home messages. So we all know what acute rhinosinusitis is, and also in children, this is not so different from what it is in adults. So we define it as acute onset of of at least 2 or more symptoms, which should be nasal blockage with nasal discharge, colored nasal discharge, so rhinorrhea or postnasal drip, or cough. And they should be less than 12 weeks because if they last longer, then we call them chronic rhinosinusitis. And actually, the story is always the same. It starts with a viral upper respiratory tract infection in children. So they have the typical runny nose, blocked nose, etc. And if actually then they get better, and after a few days, it seems that they get sick again, and quite often it's worse than the first episode, which is called double sickening. So in the second disease, they have quite often high fever, severe local pain, colored discharge, etc. And this was actually less profound in the first days. So this is the double sickening, very typical. Or you have kids with a viral infection, and then the bacterial infection is clear because of the fact that the symptoms persist actually, and quite often after 10 days even. So this is the typical course of the disease of acute rhinosinusitis in children. Then some words about the incidence and etiology of the complications. Because of the localization of the sinuses, which is in close proximity to the eyes and to the brain, we have only complications in the orbit or in the intracranial. So luckily, the majority is orbital. So 80% of the complications of acute rhinosinusitis is an orbital complication, and this is mostly seen in children under 5 years old, so really toddlers actually. And the sinuses that are involved are because of the fact that children actually have no developed maxillary and frontal sinuses, so they are not fully developed yet, which makes the ethmoidal sinuses most vulnerable to be involved. And actually, the valveless venous network, which is on the thin lamina papyracea, which is the lateral border of the ethmoidal sinuses, this valveless venous network, this network actually promotes bacterial spread from the sinuses to the orbit. And actually, this can be via direct bacterial extension. So this can extend, the inflammation can extend to the periorbital soft tissue, to the orbital bone, which can then lead to peri or orbital abscess formation, but also optic neuritis, ischemia of the optic nerve, which can cause, of course, vision loss. Another way of extension is not direct, but is just because of the fact that there is an abscess formation in this superiosteal plane of the lamina, just because of the pressure in this critical bony cage that is the orbit, you get compression on the feeding vessels, which can also cause damage to the optic nerve, which can end in permanent vision loss as a consequence. So this is actually for the orbital complications. For the intracranial complications, we see that this is luckily only in 20% of the complications. It's intracranial, and this is seen not in these very young children, but more in adolescents, like 14, 15, 16 years old, and more in males than in females. The sinus that is most often involved is not the ethmoidal sinus in those cases, but the frontal sinus. And this is again to do with the fact that at that time in the evolution of the growth, in this adolescence, there is an increased growth rate of the frontal bone, which makes it prone to infection, and also there it is covered with a network of valveless diploic veins, and this makes them very prone to hematogenious spread. So it's less common that it's really direct spread, like in the eye, due to a defect in the cranial base, for example. This is most often hematogenious spread, originating in the veins of the frontal, covering the frontal bone. And actually, unfortunately, this is even associated with some mortality, up to 10%. Some studies say 20%. So the intracranial complications can be very severe and have severe consequences. So this is a summary of the incidence and the etiology. So orbital more in toddlers, intracranial complications more in adolescent males. The orbital complications are quite logical, originating in the ethmoidal sinuses, whereas the intracranial originate most often in the frontal. The sequelae are both severe, up to blindness of one eye, most often in the orbital complications, and changes in personality, epilepsy, but even death for the intracranial complications. The mechanism is mainly through the valveless venous network or hematogenious, and this is the incidence. Then the diagnostic workup. I already mentioned something about the patient history. So you have the typical course of the disease. They have an upper respiratory tract infection. They get better, but then they get worse again. Everybody expects to GP a bacterial SIR infection. So this is what you can ask. Quite often, actually, Sure, in young children, there is not always a clear history of rhinological symptoms. So this is important to keep in mind. And actually, if we continue then with the clinical examination, you all have this kind of images, and this is the typical orbital complication. But which one is severe and which one is not? In which one do you need to do imaging and which are fine? So therefore, this patient history is important again. The two things that are really important for me is, was there already intake of oral or intravenous antibiotics? Because of this, if this kid wakes up with an eye like this, and the mother is like, yeah, he had a cold the last few days, and now the eye is like this, but we went to the GP and we just took his first amoxi this afternoon, I'm not so worried yet. For sure not if the visual acuity is perfect, there is still good eye movements, etc. It's a different story. Even if the swelling is less impressive, like here, this case on the bottom left, if the eye is also red since this morning, but there is a different history. The history is like, actually, he has already 2 weeks severe hemifacial pain, discharge from the left nostril, and since this morning he's like this. He's already 2 weeks on antibiotics, and now he also complains of painful eye movements. It's a complete, maybe this looks even worse than this, but this is more worrisome because he was already for a while on antibiotics and he still got disease progression. So that's why antibiotics is very important in the anamnesis, so in the patient history. Another thing that I already mentioned is vision. So although the eye is closed, it's always worth to, even if the patient cannot open the eye, his or herself, to open the eye and to check if mobility or mobilizing the eye movements is painful, if there is impaired vision or not. And not only impaired vision, but also proptosis. So if you see that the position of the eye is different, that it's more inferior, more lateral, more anterior than on the contralateral side. Hemosis, ophthalmoplegia, or like painful or difficult eye movements. Diminished color vision is very important because this is actually quite often the first sign of ischemia of the optic nerve. And this is because of the fact that the cones are most sensitive for an hypoxic state. And more often, the differentiation between red and green, like you can see here, is one of the signs that there is serious distress for the optic nerve. So if you have a patient and it's like, yeah, I can still see, but I have the impression that my color vision is different, or you can ask actively, is there a change in color vision? Can you still discriminate red from green? This is important because if you see that this is gone, you have actually only 50 minutes, so not even 1 hour, to do decompression before you have permanent vision loss. So this is important. I don't know if there are questions about patient history. If not, or maybe we keep them for the end, then I'll continue with the clinical examination. So of course you have the inspection, the eyes that I showed you already, but also nasal endoscopy. In children, for sure, in toddlers, this might be difficult, but I always use a pediatric flexible scope just to have an idea, is there indeed color discharge? Do we have arguments for acute rhinosinusitis? Because as I mentioned already, for sure in toddlers, it's not always clear because they often don't mention discharge or a blocked nose. They have other symptoms, like they had a sore throat, for example. It's not always so clear in these young children. So this is one thing. Then I want to mention it already here. You should not check these patients alone. So as an ENT surgeon, it's there is really no shame of asking an ophthalmologist while you are, for example, waiting for a CT scan for an advice, or the pediatricians for sure. If there was already intake of antibiotics, it might be important to see which ones, etc. In the diagnostic workup, I think imaging is really important. So if there is any doubt, if there was already intake of antibiotics and you have this kind of eye, you should do a CT. For the intraorbital complications or the suspicion, I think a CT is really the technical examination of choice, more important than MRI. So with contrast, if possible. So this is to show what your colleague ophthalmologist can add. And this was actually a very sad story. So although this looks more impressive, this one was the guy with this left fundoscopy. So this is a normal one from his right eye, in which you see the pupil is really sharp, but here you see really that there is edema. He had already 2 weeks antibiotics for acute rhinosinusitis, and now had also this red eye, and noted that there was some vision loss. And unfortunately, they did not send them immediately to us, but first to ask the ophthalmologist for his advice, and then he referred the patients to us. So this is what can happen. This guy mentioned color vision loss, and we operated immediately, and he recovered completely, but he did not recover. He had full, is blind on the left eye, actually, just to show you how severe the consequences can be. This is something that I already mentioned. So then the CT. This is my, and not only my, examination of choice for the orbital complications. And I think in the axial plane, you can see best what is going on. So typically you see close to the lamina, a superiosteal abscess formation. You see actually that the fat becomes grayish. This is very typical, and the sinusitis, so these are 3 different cases, can be unilateral, like you see here and here. These are already adolescents, actually, so they confirm they are exceptions on the rule, actually, so they are older. This is a 2-year-old girl, and there you can see that there is bilateral sinusitis. Here you can also see it in the coronal plane, but actually the axial plane is the best to assess the presence or absence of a periosteal or orbital abscess. And so you can ask the advice of your radiologist, of course, but there should be a good cooperation. I mean, if the radiologist sees this kind of images, it should not wait until the evening to send you the protocol. You can be in direct contact, and actually this is important. For the intracranial complications, of course, the symptoms will be different. They won't present with an eye like this, but they will present with neurological symptoms, and they can be very clear, but also less clear. We had last year 2 with seizures, and these were generalized tonic-clonic seizures. And then after the episode of seizures, we noted that there was a hemiparesis on the left side, but they can also present just with somnolence, or the opposite can also be true, that there is agitation, or just signs of increased intracranial pressure like nausea, vomiting, severe headache. So also their nasal endoscopy can be important, but I think their urgent imaging is really the preference examination. And here a CT scan often doesn't reveal too much except from the sinusitis, but an MRI scan is the most informative, like in the guy that I just mentioned with seizures and the hemiparesis on the left side, had here interhemispheric empyema formation, and you could see on the CT scan severe sinusitis. This is a guy that entered with also 14, 15 years old with somnolence. And you can see a huge abscess formation actually in the right frontal lobe. This is the diagnostic workup, so you know now for both kind of complications in what kind of situation you are, and actually you need to act pretty fast. In some cases, this is surgery. In other cases, this can be conservative and you can start with IV antibiotics, but in very selected cases, it's not always easy to make the decision. So this is what is in the EPOS guidelines. But of course, this is not specific enough. So what do we propose as treatment options for the orbital complications? I'll start again with the orbital and then with the intracranial ones. So there is a Chandler's classification for orbital complications, and depending on the class, which can be 1 until 5, they give you the advice to be conservative with IV antibiotics, or this is 1 and 2, or from class 3 to 5 to do endoscopic sinus surgery. Already they mentioned that actually, even if you're in a stage 2 or a class 2 and there is no improvement after 48 hours of antibiotics, then you still can opt for the surgical approach. And this is very important, that you should not be too strict. So this is just depending on the localization of the inflammation on the imaging. But for example, if you have loss of color vision or eye movements are really painful and you don't see the abscess formation, it might be advisable to start very short periods with IV antibiotics and to scan again to see if there is no evolution to a class 3 in which you need the surgical drainage. So don't be too strict with these classes. I think the clinic is the most important, and then the fact if there was already antibiotic taken or not. Some more side marks can be made about this classification, but I will do this in a few minutes. So this is just to show you actually how it is. I will show you the video in a second. If you opt for endoscopic sinus surgery, so if you see an abscess superiosteal from the lamina, it is always bloody because there is a lot of inflammation, and usually we don't operate in this acute setting. So you need to be patient, you need patties with adrenaline, and actually in these very young children, like 2, 3 years old, it might be useful to have some pediatric instruments as well. I don't use a pediatric endoscope because then you see less actually. So almost in all procedures, I use the normal endoscopes, but the instruments, the pediatric instruments, can be useful when it's really all swollen and there is a limited space in the nostrils. This might be helpful. So just to show you here briefly what happens. So here you see already, so we did only uncinectomy, we opened the maxillary sinus, and there was already almost complete demineralization of the lamina. So this is the bone that you see that I lift up now. I really go with the valproate in the abscess, and there is some gentle pressure given by one of our residents actually that shows you the evacuation of the pus. There is another one coming up. It is important to mention that you should really remove part of the lamina to have full release of the abscess. And I don't know if you could see it in the beginning. So here is some gentle pressure on the eye, and you see a really evacuation of the abscess. Okay. Another video. I want to be a bit careful because I am afraid that one of the patients is a bit fit. Yeah, you can see him a bit, so I try to move forward. Yeah, okay. Here, so this is another kid, I think 5-6 years old, and you see again, best on the axial plane, the abscess formation. There was diminished vision and very painful eye movements. And I think in this kind of cases, there is no doubt he did not get any antibiotics earlier on, but it makes no sense to wait in this case. So we did endoscopic sinus surgery, and again, it's never a nice surgery. Actually, I was looking for a nice video, but I could not find one because it's never nice in these acute situations. So you see that it's really swollen. I need to do a lot of effort to put the patties. Also, the uncinate is really full of edema. So what we try to do is we go pretty fast to the site of the abscess to get decompression, and afterwards you can really remove everything, clean it, and expose everything well. But at least because of the fact what I mentioned earlier, sometimes there is only a very small time window to operate. So I will forward maybe a bit. So you before you have your scan, and of course without scan you cannot operate. You have already 30 minutes, and you know that there is already loss of color perception, so you don't wait too long, and you go immediately to the site of to the site of the infection and the abscess. So here you see that we have again the lamina that is removed with the ball probe, and you will see afterwards if we give some gentle pressure. So this is the periorbit. You don't need to open the periorbit to be clear. It's just the lamina that has to be removed, at least for a part. So this is all periorbit. You see that somebody is giving pressure on the left eye, and so the abscess is completely drained. You can palpate. There is really a cavity, of course, formed because of the abscess that you can palpate. And this is the situation already 24 hours after surgery. It's another case. So very fast you have clinical resolution also of the orbital swelling. This is important. If you don't see this very fast, then you were on the wrong place. Although if you see so much pus, it's doubtful that you were on the wrong place. But so you really need to have a confirmation that you drained the abscess. And then you can continue with antibiotics for a short period, and this can be peros. You should not give too long IV antibiotics if you manage to drain the abscess. So for the intracranial complications, of course, there it's easier. There is no situation in which you can wait and start with IV antibiotics. Yeah, this is logical actually, and it's always the combined surgical approach. Most of the time, the neurosurgeons can start, and this is from the theoretical point of view, because of the fact that there is an abscess, there might be some overpressure, and if you open from below, then this might be, if there is a defect, suboptimal. But actually, as I already mentioned, it's quite often hematogenous, and it doesn't matter who starts. Quite often the neurosurgical decompression is just more urgent. So the craniotomy can be performed first, or the stereotactic aspiration, and then you do in the same surgery, endoscopic sinus surgery, to get source control. maybe it's not unimportant to mention actually that just because of the fact that you operate in this acute setting, it's also worthwhile to have a certain follow-up of those patients, because you might cause iatrogenic problems. And this is because if you operate in an acute stage, you have a lot more synechia formation. And I had actually one patient that I had to do a re-intervention after 6 months, because there was a synechia between the lateral wall and the middle turbinate with closure of the frontal sinus. So it's good to have some follow-up of your patients. And then some take-home messages and some remarks. I think it is really important for the orbital complications to keep in mind that if you follow the Chandler complications, that Chandler made his classification in 1970. This is really before the development of endoscopic sinus surgery. We have now angled endoscopes. We have all endoscopic training during our ENT residency. So I think there should be really a low threshold for sure when there are visual complaints towards endoscopic sinus surgery. And if you're not able to do it yourself, there is no shame of referring to a center where they are equipped with pediatric instruments, etc. And important to keep in mind is that the complications of endoscopic sinus surgery, the orbital complications, are really low, like 0.2% in general endoscopic sinus surgery. And most often, if there is an orbital complication, it's a damage to the medial rectus muscle. But actually, if you check the complication ratio of not treating a superior steel abscess, this is around 13, even up to 30% in some series. So you should really not be reluctant to bring your patient to the OR if you think that there is an abscess. For the intracranial complications, the combined approach is important. There are studies, and I will show you the references in a while, that if you don't treat the source, so if you don't make sure that the frontal sinus can drain properly, that you have recurrence of the intracranial abscesses. So it is important to do good source control. And I think that there is really a multidisciplinary approach, that you should communicate well with your radiologist, but also be in close contact with your ophthalmologist also after the surgery, that they come bedside to check if there is improvement or not, that they really, together with you, have a close follow-up for these patients. And unfortunately, we still see every year people with epilepsy, even after the surgery, or changed, like this guy with the big abscess here. I don't know if you remember, in the frontal lobe. So there was full recovery, but he still has some altered behavior, like the parents know this. So it is a pity, actually, and it is an acute rhinosinusitis that could be treated better. And if you are aware for this kind of things, this is already the start for everything. So thank you very much. We recently wrote a paper with some representative cases. If you want to check, you are very welcome. These are all the references that I used in this lecture. And I'm happy to take some questions from the audience if they have questions. Thank you.
Amazing, Laura. Thank you very much for this nice presentation. There are some questions. The first one is regarding the cultures in the setting of or during the surgery or before surgery?
Sorry, the what?
Do you do
Cultures.
nasal cultures? Yeah. Do you do nasal swabs or during surgery
Yeah, we always
you pick
take
up
them.
samples?
Sure, when they are not on antibiotics
Yeah.
yet. So if they are not before, then of course you can take the swabs. But quite often they are already for at least 48 hours on antibiotics, or they had it peros, and then they are not so useful actually. But either no exotic germs actually. So if you give a broad spectrum antibiotic like amoxiclav, you will have no issues actually. But of course, when there is already abscess formation, the only way to go is to drain it.
Yeah, I think maybe we do it mainly for medical legal reason, that for the usefulness of the culture, because at least I've never changed my
No, I
treatment
completely
because of
agree
the
actually that
results of this.
it's different if you have dentogenic sinusitis with extension to intracranial space, but for these typical superiosteal abscesses, I think there are no exotic germs, and the pediatricians like us also to take these swabs, but I don't know if they ever changed the policy, the antibiotic policy based on our swabs.
Yeah, exactly. There's another question regarding the usefulness of MRI in intraorbital complication. When do you ask
so this
for
is
an
just
MRI?
I think a CT is sufficient actually, because you want to see the localization of the abscess, and you want to know if there are special things concerning your endoscopic procedure. Is there a Haller cell? If you are going to open a maxillary sinus, I mean, and this goes very fast. It's only a few minutes, and this can even be done in young children. If they are really young, you need to do it under general anesthesia. And then also a CT is easier to get than an MRI. So in our hospital, it's more because of the availability is a lot easier for the CT. And actually, I don't need extra information than what I have on a CT that we go for the CT. But of course, if you can have an MRI, probably it is also informative. But it's just quite often impossible to get it in such a short notice. And for sure, when the patient has to be under general anesthesia, they prefer a short protocol, because the MRI is always a longer protocol. The scanning, I mean.
Yeah, completely agree. And then Dr. Moreno Luna asked, which is the most important aspect to indicate endoscopic decompression in very young children?
Yeah, so the most important aspect, I think, if there is a superiosteal abscess on imaging, there is no doubt. I will always bring them to the operating theater. I will not risk to wait for 48 hours of antibiotics. If there is an abscess, I will go and open it. Because, I mean, what you risk is that you are too late and that you have like permanent loss of vision. And it is quite often difficult to assess also the visual acuity preoperative in a child of 2. I mean, it is difficult, so you cannot really trust on the patient history. So I would go, it's different if there is not a clear abscess on imaging, but you have this very clear orbital swelling, and then you can maybe say, okay, I wait 48 hours and I check if there is a good response under IV antibiotics, if the patient was not under antibiotics yet. Because if they were already on antibiotics and it is clear that there is some visual impairment, I would also bring them to the OR. So actually really low threshold. Because he mentioned in the question superiosteal abscess, if it's there, I would go. I would never wait.
Okay, but never. But if he or she start like antibiotics. Suppose that you receive it like in 24 hours from the beginning of the of the
and you do the scan, and there is an abscess.
Yes, a tiny superiosteal abscess. You won't give a chance to antibiotics to work, at least? No? Okay.
If there is just swelling and edema, and then I agree. But if there is really an abscess, even if it's a tiny one, I mean, also, what is the risk of your endoscopic procedure? Very low. This is just the point that I think the risk of the procedure is very low, and actually you risk a lot more to wait because it can go very fast. Did I lost you? Cristobal? Are you still there? So I think Cristobal just left the session. So I think we cannot continue. Good evening, everybody, and see you soon. Bye. So are you back? Hi.
My connection was down. I'm
Okay.
very sorry about that.
No problem, but I think one of my colleagues said, wait, I will open the window because it's getting
Yeah, sure. Some of the participants are gone. I'm just for the ones who are staying, just want to share with you our next session will be a round table regarding epistaxis. We will have Alfonso Santamaria and Jose Miguel Villacampa. They will present us some nice cases about epistaxis, and then we will talk about treatment of epistaxis. We will try to do it in English, so everybody can participate. So thank you very much for participating today. Sorry because of my internet connection, and hope to see you next Tuesday in the epistaxis session. Okay, thank you very much to all. Goodbye. Bye-bye.
Goodbye.